Welcome back. Hopefully you're adequately caffeinated now for our double bill where we're going to talk about the various different acid-base disorders. So without further ado, I'm going to launch straight into it. So when you have a patient that has an acid-base disorder, the very first thing we do, obviously, is to assess the arterial pH. And this tells us whether a patient is acidemic or alkalemic. Remember the difference between EMIAs and OCs. So OCs are the underlying disorders of which there can be multiple. EMIAs, you can only be one thing, either acidemic or alkalemic or normal. The next question is to identify what the OCs are, what the underlying primary disorders are, and for that you need the PCO2 and the bicarbonate, often referred to as the total CO2 in the serum. I show here the Henderson-Hasselbalch equation. You don't actually need the equation for the boards, but I show it because it helps to, at least for me, to visualize why the bicarb and the PCO2 do what they do in the various disorders. So as you can see here, the pH is 6.1 plus the log of the bicarb over the 0.03 times the PCO2. So what this tells you is that when the bicarb goes up, because it's in the numerator, pH goes up. When the PCO2 goes up, the opposite happens, pH goes down. And from that, we get this, which we're very familiar with, that a low bicarb indicates a metabolic acidosis, high PCO2 respiratory acidosis, etc. But interpreted in the context of the arterial pH, whether it's acidemic or alkalemic. And then the third part is then to determine whether there is a normal or abnormal compensatory response to that acid-base disturbance. So all acid-base disturbances elicit a compensatory response where the body, meaning the respiratory apparatus and the kidney, attempts to partially correct that back to normal and try and minimize pH disturbances. And so determining the magnitude and direction of the compensatory response is critical here. So I have some slides here that are in sort of a pale yellow color. These refer to things that you do not need to memorize, but are shown here for your information. If you need to know these things, you carry them either on your iPhone or on a card in your pocket. But you should know how to use them. And so in the setting of a metabolic acidosis, of course, we respond by hyperventilating to bring down our PCO2. And the expected response for every milliequivalent per liter decrease in bicarb is a 1.2 millimeters of mercury decrease in PCO2. And that's a fairly reliable and fairly rapid compensatory response. Metabolic alkalosis, the opposite. Less reliable because there's a limit to how much the PCO2 is going to go up before you get respiratory drive to breathe faster. And then in respiratory acidosis and alkalosis, the kidney responds by regulating how much bicarb is excreted. And here, the important thing is that in an acute respiratory disorder, the compensation is less, usually in the first 3 to 5 days, and it takes quite a few days for the kidney to adequately respond. So a maximum renal response to a respiratory acidosis is 0.3 milliequivalents per liter rise in bicarb for every 1 millimeter rise in PCO2, but it takes a while. So in acute respiratory acidosis, you might expect less, and the reverse is true for respiratory alkalosis. Another way that you might prefer to determine this is with this acid-base diagram, where these red lines refer to the PCO2s going from 10 to 120. The x-axis is the pH, the y-axis is the bicarb, and you can plot on this where a patient is and determine approximately which disorder they're in. Okay, so in terms of the compensatory mechanisms and what you might need to know for those of you taking the boards, I think you always need to remember which is the direction of the compensation, and remember that compensation is almost never, actually is never complete. In other words, you can't compensate and restore your pH to normal. So if you have an acid-base disorder and your pH is normal, that has to mean you have two different primary acid-base disorders. The one formula that I do like to remember is Winter's formula because it's easy to remember, it comes up a lot, and it's a reasonably accurate formula. And this indicates that in a metabolic acidosis, your predicted PCO2 should be 1.5 times the bicarb plus 8. 1.5 times the bicarb plus 8, and that's accurate to within 2 milliequivalents per liter. So here are a few very simple examples just to hammer home this point. So here's a patient with a pH of 7.34, so the patient's acidemic. The PCO2 is elevated, so it could be a respiratory acidosis. The bicarb is elevated, so it's not a metabolic acidosis. In fact, the elevation of bicarb is an appropriate compensation if this were a primary respiratory acidosis. So this could be consistent with a pure primary respiratory acidosis. If you want to get precise about this, you can plug in these numbers into that table and calculate, is the bicarb elevation appropriate for the level of respiratory acidosis. Here's another example. The pH is 7.65, so this is alkalemia. Here the PCO2 is low, so this could be a respiratory alkalosis. When we look at the bicarb, so if this were just a primary respiratory alkalosis, the appropriate compensatory response should be to lower your bicarb. That would be the appropriate renal response, but when we look at the bicarb, in fact, it's high. So this would be consistent with a metabolic alkalosis. So the only reasonable explanation for this is that this patient has two alkaloses, a primary metabolic alkalosis and a primary respiratory alkalosis, and the pH is due to the combination of the two. And then here's a patient whose pH is 7.4, but clearly this patient isn't normal. The PCO2 is low, which would be expected, for example, in a respiratory alkalosis, and the bicarb is low, which you see in a metabolic acidosis. So the best explanation for why the pH is normal is that the patient has two primary disturbances, primary metabolic acidosis and the primary respiratory alkalosis that counteract each other so that the pH is normal. And this, for example, might be something you'd see in a patient with salicylate poisoning. We see that also in patients with liver failure who might have an RTA and encephalopathy. And then if you have a patient who has an anion gap acidosis, which we'll get to, there's one fourth clue that you can look into that helps determine whether there's a second primary process, and that's determining the delta-delta, which we'll address when we talk about anion gap acidoses. So that's the preamble. So let's launch straight into metabolic acidosis. So when we have a patient with metabolic acidosis, the first thing that I like to do is look at the serum anion gap, because this is a very easy way of shortening the differential diagnosis by separating patients into two groups, those with an elevated and those with a normal anion gap. And the serum anion gap, certainly as the way it's measured here in the US, is we take the concentration of sodium in the serum and subtract from it the sum of the concentrations of the major anions in the serum, which are chloride and bicarb. And this turns out to be equivalent to all the other unmeasured anions in the blood minus the unmeasured cations because of the principle of electron neutrality. Normal range of a serum anion gap, about 8 to 12 in milliequivalents per liter. So what are these unmeasured anions and cations that you're indirectly measuring by estimating the serum anion gap? Well, they're shown here, unmeasured anions, albumin phosphate, sulfate, lactate, pyruvate, other organic anions, unmeasured cations are shown here. So the important thing here is that most of them are fairly constant or contribute very little. So, for example, potassium, you'll see in some continents people include potassium in their serum anion gap, but if your potassium ranges from 3.5 to 4.5 or 5, the changes in potassium shouldn't contribute much to the anion gap. The major numerically components of these unmeasured ions is actually the negative charges on serum albumin. And because of that, if your serum albumin changes, the anion gap will also change. And so to correct for that, we generally recommend adding 2.5 to the anion gap for every 1 gram per deciliter that your serum albumin is below 4. So if you're presented with a patient with an albumin of 2, you would add 5 to the anion gap. So someone who's hypoalbuminemic and has an apparently normal anion gap could actually have an elevated anion gap. So why does anion gap acidosis even occur? So I'll give you an example to try and illustrate this. A classic anion gap acidosis would be lactic acidosis. So lactic acid is basically hydrogen ions, protons, and lactate anion. So if you create lactic acid or give someone lactic acid, what happens? Well, the hydrogen ions get buffered, usually in the blood, by our bicarbonate system. So sodium bicarbonate plus hydrogen ions are titrated to make some CO2, okay? So what happens then is that the serum bicarbonate concentration is decreased. However, the lactate stays in the blood, so that's an unmeasured anion. So another way of thinking about this is if the anion gap is the sodium minus the chloride plus bicarb, and the bicarbonate concentration goes down, but the sodium and chloride don't change, then the anion gap must increase. So the anion gap is essentially a surrogate indicator of the presence of additional unmeasured anions. And so the causes of high anion gap metabolic acidosis we're all familiar with. Everyone has their favorite mnemonic. Mud piles is commonly used, which are methanouremia, DKA, peraldehyde, iron, lactic acidosis, ethylene glycol or ethanol, and salicylates. But some of the things that are either not on the mnemonic or are not commonly thought about, rhabdomyolysis can sometimes cause a high anion gap acidosis, toluene abuse. People forget about type B lactic acidoses that are not associated with ischemia, some of which we'll talk about, D-lactic acidosis, propylene glycol, sometimes that's the P in mud piles, and pyroglutamic acidosis. And we'll touch a little bit on some of those as we go along. And this is to remind you what the unmeasured anion is. So most of the things that I mentioned are themselves not actually acids. But what happens is that they're metabolized to acid. So methanol is metabolized to formic acid. Ethylene glycol is metabolized to oxalate, oxalic acid. Propylene glycol is metabolized to lactate. Toluene's a hippurate. Ketoacidosis, the acids that generated are acetoacetic acid and beta-hydroxybutyric acid. So the anions are acetoacetate and beta-hydroxybutyrate. And in uremia, the acids that are generated are those that are generated from dietary protein intake, mostly. And they include sulfates, phosphates, and urates. Okay, so as I alluded to earlier, when you have a patient that has an anion gap acidosis, the first step is to determine the delta-delta. So the question here is the increase in anion gap proportionate to the level of acidosis? And this is based on a fairly simplistic principle that's not actually completely correct, but it's a reasonable simplification, which is that for every 1 milliequivalent per liter of acid that you add to a person's blood, the serum bicarb should decrease by 1. So that 1 milliequivalent per liter of hydrogen ions is being titrates 1 milliequivalent per liter of bicarb. And the anion gap should therefore increase by 1. So if you look at the change in the anion gap, how much it's increased, divide it by the change in the bicarb, how much it's decreased, that should be equal to 1. So that's what the delta is. The delta anion gap divided by the delta bicarbonate. And the way it's calculated is as follows. So the normal anion gap is about 10. So the patient's anion gap minus 10 would give you the delta anion gap. If a normal bicarb is about 24, then 24 minus the bicarb would tell you how much the bicarb is decreased. Divide one by the other and you get your answer. And so here's the simplistic interpretation of the delta-delta. If the delta-delta is 1, that's perfect, simple anion gap acidosis. If the delta-delta is less than 1, then what that's telling you is that there's a small increase in the anion gap, but a severe acidosis. And that would occur if there were a superimposed non-gap acidosis. So 2 different forms of acidosis, one of which increases the gap and one of which doesn't. And if you think about it, if the delta-delta was 0, meaning there's no anion gap, that would be a simple non-gap acidosis. If the delta-delta is greater than 1, that means that there's a big anion gap, which suggests that the patient's gotten a big acid load, and yet the bicarb is not as low as you'd think. The acidosis is not as severe as you'd think. And that would occur if there's also a superimposed metabolic alkalosis, some other process that's making the bicarb higher than you would expect. So here are some examples to illustrate that. So here's a 21-year-old male who's been intoxicated with ethanol and presents with repeated vomiting and is obtunded. And so the question is, what is the nature of this acid-base disturbance? So if we hone in on the pH, so if we hone in on the pH, this is acidemia. The bicarb is low, so it's obviously a metabolic acidosis. And if we look at the anion gap, it's 136 minus 108, which is 28. So that's obviously elevated. So the question then is, what's the delta-delta? So the PCO2 is also elevated, which is not expected in the metabolic acidosis. So there has to be a primary respiratory acidosis as well. So here's how we calculate the delta-delta. So the anion gap we said was 28. It's supposed to be 10, so delta anion gap is 18. The bicarb is 18. It's supposed to be 24, so the delta bicarb is 6. Delta-delta is 18 over 6, which is 3. Another way that some people do it as a sort of shorthand is they take the delta anion gap, here 18, and just add it to the patient's actual bicarb. And that tells you what the bicarb would be if the anion gap were corrected. And so if you add 18 to 18, it gives 36. So it suggests that there's also an underlying metabolic alkalosis. So either a delta-delta greater than 1, or this tells you there's also a metabolic alkalosis. Not surprising, patient says he's vomiting. So this is some of the more subtle stuff that doesn't come up on the boards, but you should just be aware that what I've told you is a relatively simplistic explanation of reality. So the normal delta-delta in a simple anion gap acidosis turns out is not necessarily 1. And the reason is the assumption of 1 is based on the assumption that all of your hydrogen ions are buffered by bicarb in the blood, but that's actually not the case. Acid can also be buffered inside cells, and the more severe your acidosis, the more intracellular buffering occurs. So on average, in a simple lactic acidosis, it's been shown that the delta-delta is closer to actually 1.6. And then even in simple anion gap acidoses, sometimes the the delta-delta can be low if those anions are excretable. So some of the classic causes of this are DKA, where keto anions are rapidly excreted in the urine, but the patient remains acidotic, or in toluene abuse, where the hippurate anion also can be very quickly excreted. So a more practical way of using the delta-delta, which is what I do in the clinic, is I don't really call it a superimposed metabolic alkalosis until the delta-delta is greater than 2. And if it's less than 1, it could be a superimposed non-gap metabolic acidosis, but I also consider that it could be an acidosis due to an acid where the anion can be easily excreted. If the patient comes in through the ER in particular, since a large number of these causes of anion gap acidosis are due to intoxications, it's useful to determine the serum osmolar gap. And this can be a very important clue to certain types of intoxications where other lab tests might take a while to come back. And so the osmolar gap is the gap between the measured serum osmolality and the calculated serum osmolality. So the serum osmolality is measured in the lab by freezing point depression, so that's the real osmolality. Calculated is what would the osmolality be from just sodium and accompanying anions, so that's why it's 2 times the sodium. Glucose, which is divided by 18 because glucose is in milligrams per deciliter, and the molecular weight of glucose is 180, and blood urea nitrogen divided by 2.8 because there are 2 nitrogens in urea that have molecular weights of 14 each. Oftentimes, so just to back up, so a normal quote-unquote osmolar gap is one that's less than 10, or put another way, we don't generally tend to consider the gap to be elevated for sure unless it's greater than 10 milliosms per kilo. Frequently, we get patients that come in with alcohol intoxication, but they are often also ingest something else. So it's useful to know how much does ethanol contribute to the osmolar gap, and if we exclude the contribution of ethanol, can we find other things? So it turns out that ethanol has a molecular weight of 46, so if you know the blood alcohol level in mg per deciliter, you divide it by 4.6. That's the contribution to osmolar gap. And then some of these other toxins that could be in the blood, you can calculate their contribution by dividing again by 1/10 of their molecular weight. These are not, I should say, things that you're expected to do for the boards, but on the wards, these are and in the ER, this is a really useful thing to be able to know. So in terms of patients who come in with intoxications, they can have an anion gap acidosis, an osmolar gap, or both. So an example of someone with an anion gap acidosis, but normal osmolar gap would be salicylates. Salicylates do not contribute to the osmolar gap. Examples of these that contribute to the osmolar gap, ethanol, ethylene glycol, propylene glycol, and methanol, all cause an anion gap acidosis. In the case of these 3, they're all metabolized to acids and acid anions. Ethanol itself is not metabolized to an acid, but it stimulates alcoholic ketoacidosis. So it's the keto anions that cause the anion gap acidosis. And then these have to be differentiated from isopropanol poisoning, which is relatively benign. It's also a small alcohol, and so it raises your osmolar gap, but it's not metabolized to an acid, so it does not cause an anion gap acidosis. So briefly, I'm going to run through some of the causes of anion gap acidosis and go into a little bit more detail about them. So one of the most common ones that we all see is ethylene glycol poisoning. Patients appear inebriated, but they don't smell of alcohol. So this is different from ethanol and different from methanol. Some of the things that you can see include heart failure, ARDS. They can get acute kidney injury due to ATM. What's different from methanol poisoning, which is otherwise very, very similar, is they don't have eye toxicity, so they don't develop optic disc edema or blindness. As I said, they have an anion and osmolar gap acidosis. Sometimes, in fact, most of the time, they also have a minor elevation in serum lactate. But don't be fooled. If you see someone with anion gap acidosis and their lactate's up a little bit, don't assume that that's the cause. And one of the useful tips is that if your lactate in your lab is measured in millimoles per liter and your anion gap is in milliequivalents per liter, you can translate how much of that lactate contributes to the anion gap. If it's in mgs per deciliter, you have to convert it to millimoles per liter. Because ethylene glycol is metabolized to oxalate, it can chelate calcium and cause hypocalcemia. The calcium oxalate can deposit in the renal tract and cause microscopic hematuria and crystalluria, which can include calcium oxalate dihydrate crystals, which are these classic envelope-shaped crystals, or monohydrate, which are needle-shaped crystals. Because the vast majority of ethylene glycol poisoning in this country is from antifreeze, from engine coolant, which in this country has fluorescein added to it so that car mechanics can diagnose leaks in the car, it's frequently found that patients that have ingested this have fluorescent urine. So if you have a UV lamp, like a Woods lamp from Derm Clinic, you can check whether urine fluoresces. Limited sensitivity and specificity, but sometimes a neat thing to do. So remember that ethylene glycol itself is what causes the osmolar gap. It's a small molecule, uncharged, so it generates a large increase in osmolality. But it's the metabolites that are toxic to the tissues. And the metabolites are formed by the action of alcohol dehydrogenase, the same enzyme that metabolizes ethanol. And glycolic acid is probably the most toxic. So the treatment is to inhibit alcohol dehydrogenase. In the old days, we did that by giving patients ethanol. Nowadays, in this country, giving the specific inhibitor fomepizole is much more common. Glycolic acid itself can be metabolized through endogenous pathways where pyridoxine and thiamine are cofactors. So sometimes people will give this relatively benign but unproven. Again, this is small print stuff that it won't come up on the boards, but we see these cases every once in a while, patients that have either osmolar gap or anion gap, but not both. And the reason for this is simple. So when a patient ingests ethylene glycol, if you catch them acutely, they'll have a large osmolar gap due to the ethylene glycol. But if they haven't had time to metabolize it yet, there would be no anion gap acidosis. Over time, the osmolar gap falls and the anion gap rises. And in theory, if they're left late enough, they would just have the anion gap acidosis and minimal osmolar gap. In terms of the management of ethylene glycol poisoning, GI decontamination has very little role because ethylene glycol is quite rapidly absorbed. Sodium bicarbonate has a limited role in trapping glycolic and glyxylic acid in the urine, but primarily it's to correct the pH. As I mentioned, one of the first things that you want to do if you suspect ethylene glycol poisoning, and often before you've confirmed it by measuring the level, is to give fomepizole. We generally don't treat hypocalcemia if it's asymptomatic because raising the serum calcium will increase the calcium oxalate product and increase deposition of calcium oxalate in tissues, which is quite toxic. And then hemodialysis, as you know, is extremely effective at clearing ethylene glycol because it's a very small molecule that's just distributed in total body water. These are the indications for giving fomepizole that are recommended by the American Academy of Clinical Toxicology. I won't go into that. Some of the advantages of fomepizole. Who needs to have dialysis? Well, there's no hard and fast rules. Here are some of the recommendations. threshold level of 50 mg per deciliter or an osmolar gap of greater than 10. Oftentimes we don't get the ethylene glycol level back on time. It can take a few hours or a few days depending on where you are. So you're left with trying to make a reasonable decision based on the osmolar gap and these features. So a patient with acute kidney injury should be dialyzed, not only for their acute kidney injury, but because the whole point of this is to inhibit metabolism of ethylene glycol and then allow it to be excreted. But if they have acute kidney injury and can't excrete the ethylene glycol, it'll hang around for a long period of time. So those patients have to be dialyzed. Obviously, patients with severe acidemia or that are worsening despite treatment. Methanol intoxication has a lot of similarities to ethylene glycol. So here are some of the differences. Patients have an alcoholic fetor, if you smell it carefully enough. They do have eye toxicity that can manifest as dilated pupils, retinal and optic disc edema, and blindness. Like ethylene glycol, there's both an anion and osmolar gap, although how much of one or the other depends on whether you're early or late in the intoxication. Patients do not have detectable serum ethanol levels. And unlike ethylene glycol, they don't have hypocalcemia, hematuria, or crystalluria. Some of the more unique things to methanol is it can cause rhabdomyolysis, and it can cause acute pancreatitis. The treatment for methanol poisoning is the same. So you're inhibiting here alcohol dehydrogenase's metabolism of methanol to formic acid, which is the toxic metabolite. And it's also easily dialyzed. Some of the things that are recommended are to treat acidemia more aggressively than you would for ethylene glycol, because formic acid, the protonated form, is more toxic than formate and gets into the CNS and the retina. And so if you maintain a normal or even alkaline pH, you can convert the formic acid to the deprotonated form. And folic acid is sometimes used as a cofactor for endogenous metabolism of formic acid. If patients need hemodialysis, it's recommended to avoid heparin because there's a risk of intracerebral hemorrhage. Salicylate intoxication can cause myriad manifestations, some of them very nonspecific, particularly in young children and in the elderly. Some of the more specific things that to look out for when you see a patient with come into the ER are obviously tinnitus and deafness, relatively unusual symptoms for other intoxications, and then the triad of high vital signs, that's how I like to think of it, fever, hyperventilation, and tachycardia together are quite classic for salicylate intoxication. The acid-base disturbances, they frequently have mixed acid-base disturbances and can present with pretty much any type of combination. But in adults, by far the most common is an anion gap metabolic acidosis combined with a primary respiratory alkalosis. And here the metabolic acidosis isn't actually due to the salicylate itself. Those concentrations aren't high enough, but it's due to the generation of lactic acid and ketoacidosis. In treating these patients, some of the things to remember are we try not to intubate patients unless it's absolutely necessary. It's a mistake to ventilate patients for respiratory fatigue because in general these patients are hyperventilating to compensate. If you intubate them and are unable to maintain that level of hyperventilation from positive pressure ventilation, then their arterial pH will actually drop. And that's a problem because salicylic acid gets into the CNS and there's a major cause of morbidity and mortality. So if you keep their serum pH on the alkaline side, it'll convert the salicylic acid to salicylate, which can't penetrate the CNS. Gastric decontamination, sometimes with multi-dose charcoal, is recommended. As I said, one of the goals is to make sure that the serum is alkalinized, and so this decreases CNS penetration. This is used for a second goal, which is to alkalinize the urine if possible. And by if possible, I mean if the patient has reasonable renal function. If the patient has AKI or advanced CKD, you can alkalinize the blood but not make the urine pH go up. But if you can get the urine pH up, ideally as high as 7.5, you would trap salicylate in the urine and increase its excretion. So this is alkaline diuresis. And we generally use isotonic bicarb drips to do that. Don't forget that patients who are getting this, so salicylate poisoning often causes hypokalemia, but once you start the bicarb drip, that's made substantially worse. And then salicylate is, of course, well dialyzed as well. Alcoholic ketoacidosis. The symptoms of this are pretty nonspecific, but often nausea, vomiting, abdominal pain, and abdominal tenderness. Obviously, these patients have a normal glucose. Remember that it's the beta-hydroxybutyrate that's usually elevated and disproportionately, and they often have no acetoacetate. So it's a mistake to look for that. Importantly, they may not have a positive serum alcohol level. Often these patients get sick and stop drinking, and it's a day or two after they stop drinking that they develop a severe enough ketoacidosis to present. So a third of patients have undetectable alcohol in their serum, and they often also have a concomitant but modest lactic acidosis. And the treatment is, of course, conservative, just give dextrose-containing fluids. D-lactic acidosis is in the differential for an anion gap metabolic acidosis and can sometimes be unsuspected. So the pathogenesis of this is as follows. So our bodies generate L-lactate, so D-lactic acidosis is not something that our own bodies generate or mammals generate. This is generated only by bacteria, and it's generated from carbohydrates. So this happens when carbohydrates that are usually in the early part of the gut gain access to the colon and stimulate bacterial overgrowth and metabolism of those carbs to D-lactic acidosis. So a classic example of this is short bowel syndrome with malabsorption. And the presentation is mainly with changes in mental status that are associated with ingestion of carbs, and they present with an anion gap metabolic acidosis. But if you send a lactic acid to the lab, they will check for L-lactic acid and it'll be normal. So you have to specifically order D-lactate either in the blood or in the urine. These episodes spontaneously resolve if these patients are left NPO, and often they present multiple times to the ER with these symptoms that resolve spontaneously before someone makes the diagnosis. Propylene glycol poisoning is an iatrogenic disease due to the vehicle that is used in certain types of IV drugs. In the old days, when ICUs used a lot of Ativan, lorazepam, this was a major cause of metabolic acidosis because 80% of the volume in the Ativan drip is actually propylene glycol. But you can see some of these other commonly used IV medications also have a substantial amount of propylene glycol. So occasionally a patient getting very large high drip rates of these can develop this problem. Finally, a useful thing to remember, this is not a huge clinical problem, but it's often a cause of a puzzling cause of an anion gap acidosis in the ICU, for example, is pyroglutamic acidemia, also known as 5-oxoprolinemia. This occurs more commonly in females, usually critically ill, often with sepsis or SIRS. Concomitant liver and renal failure can predispose to this, as can malnutrition. The major cause in this country is acetaminophen use, In other countries where flucloxacillin is used a lot, this antibiotic is also a cause. And these patients present with anion gap acidosis that's due to an elevation in pyroglutamic acid that you can detect either in a blood or a urine. And this shows how this occurs. So this is the metabolism that generates glutathione, which is our intracellular reducing agent. And it's generated from the amino acids glutamate and cysteine by gamma-glutamyl cysteine synthetase. This is the intermediate that then generates glutathione. And then what happens is the glutathione feeds back and inhibits this enzyme to shut it off. And that's how you get normal amounts of glutathione. If you deplete glutathione, so that's what acetaminophen does, is actually uses up glutathione, as does sepsis, then this feedback loop is diminished and more gamma-glutamyl cysteine is made and accumulates, overwhelms the ability to generate glutathione. And so there's a salvage pathway where gamma-glutamyl cysteine is converted to pyroglutamic acid, which is also called 5-oxoproline, two names for the same compound. And so that's what causes the anion gap acidosis. It's not clear whether this really causes any symptoms. As I said, most of these patients are already critically ill in the ICU, but it can cause a significant anion gap acidosis that's problematic and puzzling if you don't suspect this. Here's some suggested reading.